was implanted. So we had to explant the inverted IPCL and reimplant a correct IPCL. 2-year follow-up, the patient is stable with a vault of 575 microns. The second patient, this was a case of repeated rotations of the ICLs in the left eye. The visual gain was 6/9 post-op. Despite rotating ICL, redialing the ICL once, there was again another redialing had to be done, and the toric ICL had to be exchanged with a bigger size because of 2 failed attempts. Follow-up of 6 months, there was a stable vault of 435 microns. Case 3, this was a 23rd-year-old female with a good post-op gain of vision. However, on the day 1, the vault was 1120. We observed this eye. 1 month, the vault remained 1250 microns, and 3 months, the vault was 1200 microns. So why such a high vault? Is such a high vault acceptable? These were certain questions that came to our head. For the left eye, we kept her under observation, and for the right eye, we planned after 3 months of the left eye surgery for the right eye, and the ICL sizing we had deliberately reduced. The right eye was 12.1 in size, whereas in the left eye it was 12.6. Case 4, this was a 30-year-old female with an uneventful phakic IOL implantation, good post-op gain. However, in the left eye, as we can see, it was an extremely low vault of 52 microns only. This was almost 1 month in the left eye. So the management was ICL exchange was done with a bigger size. Even on 1-year follow-up, the vault was found to be stable. This was the post-op result, 136 microns. We have kept her under observation, and even after 2 years of follow-up, the vault is stable and there are no signs of any cataract development. So coming to the discussion part, in the first case, there were left eye reverse orientation of phakic IOL was seen. ASOCT was done. ASOCT was the most important modality to diagnose this condition. In the case 2, the left eye, there was rotational instability of the ICL. And we had, in spite of redialing it twice, we had to exchange it for the bigger size. In the case 3, the left eye, there was significantly high vault, which was higher than 1000 mm, and therefore the vault of one eye was kept under observation to decide the size of the ICL in the other eye. In the case 4, the left eye had extremely low vault. In such cases, of course, as I had already mentioned, the low vault, stable, less than 250, stable 1-year post-operatively have been reported, so we kept that under observation. Thank you. All I can say is I can conclude that meticulous and accurate measurements are needed while planning a phakic IOL, and we have to keep them for long follow-ups. That's all.
What were the method you used for calculating the white to white?
Sir, we at our center, obviously we do the IL master and the pentacams. However, we rely on the digital white to white. And digital calipers.
Do you have experience of using the lasso software for getting the predicted vault size? Because
no, sir, we have not used it.
One case you had a low vault and one case you had a high vault. So what could be the cause?
We did all the investigations. We even did, like, everything was the management, the preoperative planning part. We went through all the documents, the gonioscopy, the any histories or that regards to the patient. But we could not come up with any particular reason as to why there was a huge surprise post-operatively. So
actually, we measure the white to white. Actually,
yes.
What measurement we need is the inner sulcus diameter.
Yes, sulcus
so
to sulcus.
Sometimes it may be variable.
Yes,
it may not correspond to white to white. So that time UBM and all will help.
UBM we don't routinely do in every patient, so we can have missed that, sir.
Good afternoon all. So my topic is about nerve tracking in different lenticular procedures. So lenticular extraction procedures, as we all know, are known to cause lesser dry eye, the lesser biomechanical changes, and faster corneal nerve regeneration when compared to the LASIK procedure. So these are few studies which show that the percentage changes over time in the nerve fiber density between SMILE and femto-LASIK. It showed better corneal nerve regeneration with the LASIK. So the question is, how does it translate to our post-operative outcome? So these are the serial scans of confocal microscopy from preoperative period to 1, 3, and 6 months post-operative period, which shows that there is slower regeneration in the LASIK group. So this translates to a poor ocular surface, which is indicated by the poor non-invasive breakup time. So as we all know now, there are various Calyx platforms that are available currently. So these are the three platforms available: Zeiss Vizumax, J&J Elita, and Schwinn Datos. I have no financial disclosure here. So these are three different machines, variable laser energy settings. They have unique lenticular profiles. So let's see how they differ. There are variable energy laser energy settings. So energy per pulse when compared to SMILE, which was 110 to 150 nanojoules, it is 40 to 70 nanojoules in Elita and 75 to 135 nanojoules in ATOS. Further, if you see in ASOCT, we found out that in SMILE we had plano-convex profile when compared to Silk and SmartSight, that is ATOS, wherein we found that the lenticular profile was biconvex. So we did a 3D reconstruction of the lenticular profile using the ASOCT maps, and these are the 3D profiles that we see. Same, the plano-convex versus the biconvex profile. That brings to our research question. So how do these varied lenticular profiles impact the corneal nerve regeneration? So we did a prospective comparative clinical study wherein we quantified the corneal nerve regeneration in terms of corneal nerve fiber length and density with all the three different lenticular platforms. So we had 20 eyes in each group. The age and refractive error was matched. All the patients underwent basic clinical evaluation, routine imaging, which includes Pentacam MS39 Corvus, and serial scans in confocal microscopy, followed by lenticular-based refractive surgery in all the three platforms, in each group containing almost 30 patients. So we evaluated corneal nerve fibers. As you can see, the red color fibers are the principal nerve fibers and the blue ones are the secondary nerve fibers. We mainly checked for the length and the density of the fibers. So these are the serial scans of confocal microscopy, which shows that in the biconvex profile lenticule, there was good corneal nerve regeneration when compared to the SMILE group. So this is the statistical analysis showing superior regeneration of corneal nerves in terms of density and length with biconvex lenticules as compared to the plano-convex technology, which again translates to a healthier ocular surface and also tear film integrity. So how does the lenticular shape affect nerve regeneration? As you can see here, if the plano-convex in the plano-convex lenticule, there is a side cut, which will cut more nerves when compared to the biconvex profile. So this is a short animation which shows the difference between the two procedures. So the biconvex, because of the lesser side cut, it will preserve the nerve trunk. So not more of the nerves are cut, which will translate to a healthier surface in terms of regular epithelium. And also we can see a faster corneal nerve regeneration. To conclude, our results also showed that the change in corneal nerve fiber density was significantly lesser in the biconvex group when compared to the plano-convex group at 1, 3, and 6 months post-operatively. And similar changes were seen in terms of length of the corneal nerve fiber as well. To conclude, we knew that the lenticular extraction procedures have lesser chances of dry eye, better corneal regeneration, lesser biomechanical changes. But what the study adds is basically the biconvex shape lenticular profile and lesser cumulative energy in Silk, and the tissue saving through optimized lenticular geometry in SmartSight, that is ATOS, will lead to faster and more superior corneal nerve regeneration when compared to the plano-convex. So to conclude, we found that there is superior corneal nerve regeneration in the newer laser platforms when compared to the traditional ones. Thank you.
Did you also check for the corneal sensations?
Corneal sensations clinically, yes, ma'am. But it usually in the immediate post-operative period, both had similar,
So
results.
how did you check the corneal sensation?
Usual way with the cotton But
Doesn't
yeah,
really
but we cannot
quantify.
quantify it. So that is why we used confocal microscopy to study the nerves.
But does the structural thing translate to functional effect?
So that is why we studied the tear film matrix, ma'am. That is why, so it is indicated by the non-invasive breakup time. We clearly saw that there was a difference between the, group 1 and group 2, that is the biconvex and the plano-convex.
Thank you.
Thank you.
Dr. Anushri Bhatkal.
Good afternoon, everyone. The topic for today is, can epithelial mapping be a surrogate marker to predict refractive surgery outcomes? So in our routine refractive surgery practice, despite thorough pre-op workup and normal parameters, we still come across certain unhappy patients. Though 80% of the patients are happy, we do come across 15 to 20% patients who are unhappy post-surgery. They will complain of poor quality of vision, irritation, burning, burning sensation, ocular surface discomfort, and glares and halos. So, it's not moving forward. Yeah, what could be the reason for these variable outcomes? So, the answer usually lies in the wound healing cascade post-surgery. And to understand this, we can look at the immunological response and the nerve regeneration. However, it is difficult to do so due to lack of time, equipment, and elaborate research models. However, this wound healing cascade after refractive surgery also results in epithelial remodeling, and this has been proven in various publications in the past. Various patterns of epithelial remodeling are seen after refractive surgery. However, there is a need to correlate this epithelial profile to the clinical outcomes after refractive surgery. We know that there is a vast literature supporting that the epithelium remodels as a consequence of the refractive surgery. However, in the presence of ocular surface inflammation, the remodeling is exaggerated, which can have implications on the postoperative outcomes. This brings us to our research objectives. First, to assess the pre and the post-operative epithelium status of patients undergoing refractive surgery, to identify if epithelium has an impact on the quality of vision, and to assess if the epithelial profile can serve as a surrogate marker to predict post-operative outcomes in refractive surgery. So this was a study. It was a prospective observational study in which there were 100 patients undergoing refractive surgery without any pre-existing ocular surface disease, and patients were myopes and refraction matched. Apart from the routine testing, they all underwent epithelial imaging on the MS-39. All underwent LASIK without any prior treatment. The optical zone flap depth was constant, and the same surgeon operated on all the patients. Epithelial imaging was repeated post-surgery, and the epithelial aberration data was also noted. We also looked at the subjective visual quality based on the VFQ25 questionnaire for all the patients. Coming to the results, 71 patients had a regular epithelium pre-surgery, which were considered group 1, and 29 had irregular epithelium pre-surgery, which was the group 2. Irregular epithelium was defined when the difference between the center and the peripheral epithelial thickness at the 6 mm zone was more than 7 microns. Coming to the results, we looked at the epithelial thickness post-operatively. So the group 1, which already had a regular epithelium pre-surgery, in them 91% of the patients had regular epithelium even after the surgery. Group 2 had only 18% had a regular epithelium post-surgery. 94 patients of group 1 had a VFQ25 score of less than 80, and 82% of group 2 patients had VFQ25 score of more than 120. That means they were unhappy with their quality of vision. When we looked at the aberration data, 85% patients in group 1 had a coma RMS of less than RMS difference of less than 0.5, whereas the 94.7 had epi-HOA RMS difference less than 0.5. In group 2, 62.6% had a coma RMS difference of more than 0.5. So to understand the wound healing, we delved further, and we also did a confocal microscopy pre-operatively for these patients. 91% of the group 1 had normal confocal findings, that is healthy nerves, but 86% of group 2 had either dendritic cells or microneuroma suggestive of an underlying ocular surface inflammation. So we actually looked at these three types of patients. The one with healthy nerves had a normal tear biomarker inflammatory levels, and the patients with immature dendritic cells and microneuromas had raised biomarker levels preoperatively. Also, their epithelium in the patients who had healthy nerves had a regular epithelium, but those with immature dendritic cells and microneuromas had epithelial thickening and irregular epithelium, suggestive of underlying ocular surface inflammation. When the surgery was done on these patients, the inflammation was exaggerated post-surgery, especially in patients with dendritic cells and microneuroma, and the epithelium was highly thickened and irregular. Also, that it reflected in the biomarker levels post-operatively and the quality of vision. So thus to summarize, if the preoperative status was healthy, the patient was happy post-operatively as opposed to the patients who had underlying ocular surface inflammation. This reiterates the fact that patient inflammation drives changes in the nerve cell density and dendrites, which results in diminished supply of neural factors to ocular surface, resulting in injury to the epithelium. Thus, the epithelium is indicative of the underlying neural health and biomarker status and can be a surrogate marker of the ocular surface health. These patients need treatment, pre-surgery treatment with immunomodulators and steroids and procedural treatment if required, which will bring down the pre-operative subclinical inflammation, improving the post-operative outcomes. Thus, our study basically talked about epithelium remodeling having an impact on quality of vision and the underlying ocular surface inflammation affecting the epithelium remodeling, which adversely has implications on the post-operative outcomes. Thank you.
So if there is a irregular epithelium preoperatively, you think of ocular surface inflammation in terms of
Yes,
dry
so
eye.
that's what we're trying to say.
Now,
That
anything else we can think if there is a irregular epithelium preoperatively? One you said it is in terms
yeah,
of ocular
so
surface
it's an
inflammation,
irregular
but,
cornea with like irregular, that can cause, like it can be a masking effect in cases of thinner corneas. But those kind of patients were excluded from the study. We ensured that they didn't have any ectasia or any thin corneas.
okay. What message you would like to give if there is a
So we want to say from this that we have correlated the epithelium with confocal and the tear biomarkers, which correlated very well. So if the epithelium is not just thick, it should be irregular also. If it is irregular, then it is better to just pre-treat the patients with steroids or immunomodulators and good lubrication at least for 4 weeks, and then take up the patient for surgery. So that even though, so because some patients are 20/20 but not happy with the quality of vision, which is very difficult to explain at times. So if the epithelium remodels regularly, there is going to be thickening, but at least if there is no irregularity, they will be happy.
So also it can be very early ectasia also. That is what we are.
Early ectasia,
So
yes, sir.
you have to be careful. Not only the
Yeah. So
dry-
actually in MS-13, we also can look at the stromal elevation. So that was not present. We ensured that that is not there in these patients.
So it was only epithelial irregularity.
Yes, ma'am.
So were these patients long-term contact lens users? Did you have a history of how long they'd been off their
yes.
contact lenses?
Yes, ma'am. So if you have a very chronic contact lens user, we ensure that the patients are off contact lens for 3 to 4 months, and we start them on lubricants, and then only we take them up for surgery. So that is something we follow. Thank you.
Yeah, we can call the next person, Dr. Naren Shetty.
Good afternoon, everyone. I'd like to thank AIOC for giving me this opportunity. These are my financial disclosures. I'm sure each one of us had cases where you have done the perfect workup for a phakic IOL patient, you have done the perfect calculation. Even in the surgery, in the OT, the surgery has gone perfectly, and next day you see the patient also smiling, the patient is 6/6 vision, so you're also very happy. But when you look at the slit lamp or the OCT, you have a high vault or a low vault. Now, why does these kind of cases happen to us now and then? So this mainly happens is we rely only on the horizontal white-to-wide, and also we do certain assumptions which we think it's always true. That is, the shape of the limbus is always elliptical, horizontal white-to-wide is always maximum, vertical white-to-wide is always minimum. And this is where things go wrong. Now, the research question is, can we actually think of a new formula where we can predict these walls before surgery itself so that we get the perfect sizing? So to do this, we thought of an idea where we took the pentacam densitometry scan, and the values in 256 grayscale was plotted. The rate of change of the densitometry was noted so as to mark the wide to wide exactly, and this was done 360 degrees. And we found something interesting when we looked at this particular data. What we found was the shortest wide to wide correlated beautifully with the steep axis, which was very interesting, and we even published this data. But keeping aside this coincidental finding, basically the same way we calculated the max wide to wide, minimum wide to wide, max angle, minimum angle, horizontal wide to wide, vertical wide to wide. Now we took all of this data and also the data from the pentacam, the refraction, the ICL parameters, and also the UBM predicted wall size, and put all of this into an AI, and we found something very interesting. So if you look at the predicted wall, the coefficient of determination was 0.74. Basically, the closer to 1, the better it is. And also the interclass correlation coefficient was 0.92, which was extremely, extremely good. But let's look at all the literature, which all the formulas which are already there. So the R square ranges from 0.06 to 0.3, 0.4, and the best, which is the Lasso formula, where the R square is 0.68, and our new formula is performing even better than this. So to conclude, with the novel 3D corneal diameter profile and AI-driven ICL sizing, we are able to estimate the post-operative vault much more accurately with the R square of 0.74. That way, we reduce the chances of vault surprises post-surgery. That way, we give more confidence for doctors to start a phakic IOL practice, and also surgeons who are already doing less amount of anxiousness. Thank you so much for your time.
So the measurements which are fed into this are the pentacam measurements into the new AI formula?
Yes, sir. So the pentacam measurements are also added, sir. The what extra thing which we did is our own formula, that the 3D corneal modeling. So what we do is we take the data, the densitometry scan of the pentacam, we take that data, and then we look at the change in the rate of change and perfectly mark the wide to wide so that the errors don't happen. Because a lot of times, when you manually do it, errors happen. So we exactly measured the wide to wide, and we did this 360 degrees and then plotted it, so that we get that the exact axis of the shortest wide to wide. And this data normally we don't get everywhere, and the perfect axis also. Yes.
Very interesting.
So this is this particular formula is based on 100 cases right now. We are adding more data, but if you look at all the published data, it's ranging from 100 to 120 cases, which is already published. But we have tested in a lot of patients, and it looks very promising, and definitely we have to add more and more patients.
But tell me one thing, you're still placing your ICL in the same 0180.
Right.
So whether there is, the diameter is shorter somewhere else, or how does that help you in the sizing? Because you're not changing your, orientation.
Understood, ma'am. Absolutely, ma'am. So basically, so the information about the shortest wide to wide, and I mean that was a different correlation to the steep axis, ma'am. But what we are doing with this data is this is a unique data which normally wasn't available for AI to read and predict. Okay, look, if you have this kind of minimum wide to wide or maximum wide to wide, choose this ICL size. That is what the AI is doing. It's not predicting the position, ma'am. What it's trying to do is using new data so that the prediction of post-operative vault will change. Actually, moving forward, that is a very interesting point. That is what we want to do. The next is, unrelated to this, ma'am, but we are looking at what if we position toric lenses, be it toric normal cataract lenses, posterior chamber lenses, or phakic lenses in the shortest wide to wide axis, so that you are perfectly aligning the steep axis. That is something that we are yet to come to, but as of now, we are using that data only for the AI formula to predict better the vault, post-operative vault. Thank you, ma'am. Thank you.
Your results were validated?
Sorry, sir?
The post-op vaults.
Oh yes, that's the stats which I showed. So the coefficient of diffusion, it's basically if you see that value, if it's closer to 1, the more accurate and more better it is. And we compared it with every other published data. We are right now one of the highest, and we feel it's going to be more stronger as we keep adding more data, sir.
Thank you.
Thank you, sir.
Dr. Rohit Kumar Gupta.
Good afternoon, everyone. I'll be talking on comparative analysis of white-to-white measurements from different devices for phakic IOL sizing. So phakic intraocular lenses are clear implantable lenses for correcting high degrees of refractive error, and they are excellent options for vision correction in patients unsuitable for laser vision correction, the advantage being they preserve the accommodation. The horizontal white-to-white diameter decides the ideal size of the phakic IOL and can be measured by various tools. So all these devices give readings which are slightly different from each other, adding to the confusion of choosing the accurate white-to-white. So the aim of our study was to compare white-to-white measurements obtained from digital calipers with Pentacam and IOL Master 700. We assessed if digital calipers values can be used for IPCL size calculation, which was done by observing the post-op vault on ASOCT. So our study was a single center, single surgeon, retrospective and cross-sectional, where we included patients above 18 years of age, not suitable for corneal refractive surgery and no previous corneal refractive surgery, and the refraction was stable. We had 50 eyes of 25 patients included in our study. For IPCL sizing, as we all know, if ACD is more than 3.5 mm, 1 mm is added to the measured horizontal white-to-white, whereas if the ACD is less than 3.5, 0.5 is added to the measured horizontal white-to-white. And then the calculated lens size between available lens diameter were rounded down for ACD less than 3.5 and rounded up for ACD more than 3.5. Horizontal white-to-white diameter was measured using IOL Master 700, Pentacam HD, and digital calipers. Vault is the distance between the posterior surface of the IPCL and the anterior surface of the crystalline lens, and it's measured on ASOCT on 6 weeks follow-up. Coming to the results part, the mean white-to-white measurement from Pentacam and calipers were almost similar and close to each other. And while comparing the Pentacam and the calipers, the bias was the minimum and the correlation was the maximum when you compare the Pentacam and calipers. While using the digital calipers, maximum patients had a vault of in between 750 to 1000 on ASOCT 6 weeks post-op. Coming to the discussion part, earlier studies had shown that IOL master measurement have highest reliability in measuring white-to-white, but in subsequent studies, it showed that there's no correlation between Pentacam and IOL master white-to-white. And in one of the studies, it showed that they recommended a correction factor of minus 0.34 for proper vaulting with IOL master. In accordance with our study, there was a study which showed that there is a strong correlation between Pentacam and calipers white-to-white measurement. Hence, to conclude, the precise horizontal white-to-white measurement of the cornea is a key parameter for achieving potential optimal size phakic intraocular lenses. Readings of white-to-white measurements using Pentacam and digital calipers were very close to each other, hence indicating their interchangeability. IPCL sizing was acceptable with white-to-white measurements of digital calipers and provided optimal vault. And corneal white-to-white measurements using digital calipers is a reliable method and prevents over or undersizing of the IPCL. Thank you.
You are using the IOL Master 700
Yes,
or the
sir.
500?
Yes, 700.
And the digital calipers measurement which you all were taking,
Yes,
were you
sir.
taking it in the supine position or?
Supine positions.
So if you had a difference between your digital caliper and IOL Master Pentacam,
Yes, ma'am.
then did you take an average or how did you go about it?
No, ma'am, most of the times the digital calipers and the Pentacam readings were almost close to each other, and when we checked with the ASOCT post-op vault, it was like matching with it. So we used to take the average of the digital calipers and the Pentacam.
For each and every patient, you took the average
Yes,
of the
ma'am.
two.
Yes, ma'am.
The measurement is also subjective. So the single person was done in both pentacam and. Thank you.
Next, I would call upon Dr. Mamata Lakancha.
Good evening, everybody. My topic for today is comparison of clinical efficacy of ICL implantation with and without use of an OVD. In introduction, I would like to say that phakic intracolumnar lens implantation is widely used for high myopia, even for hypermetropia and astigmatism. It is an FDA-approved technique. So to insert the lens, like any other intraocular surgeries, we use ophthalmic viscosurgical devices. OVDs are useful in two ways. Firstly, it maintains the anterior chamber. Secondly, it also protects the corneal endothelial cells. So, but the retained OVDs, if they are remained in the post-operative period, they cause blockage of the central hole of the ICL, and they also mechanically block the trabecular meshwork. So these complications contribute to high IOP spikes post-operatively and also high inflammation in the post-operative period. So the mean OVD technique, which is applied by experienced surgeons in recent years to reduce the occurrence of high IOP after surgery, and the post-operative recovery is rapid. So under the premise to further minimize the risk of OVD-induced post-operative complication, OVD technique can be replaced by non-OVD method, which is done under a BSS solution, continuous irrigation of BSS solution to maintain the anterior chamber. This was a retrospective cohort study of 100 eyes of 50 patients. All the surgeries were done by a single surgeon. The follow-up periods were on the first day, 15th day, then 3 months and 6 months. Each group had 50 eyes of 25 patients. Patients in the study underwent a thorough anterior and posterior segment examination, and the IOP was measured by non-contact tonometry, biometry was done, endothelial cell density was measured, and retinal assessment was done. The phakic IOL used was ICL, which is by a star surgical lens. Time taken for the surgery was also recorded for both the groups. Inclusion criteria was age between 20 to 40 years. Refractive error, which was stable, less than 0.5 diopter of change in past 1 year. IOP of less than 21. ACD of more than 2.8, and endothelial cell density was more than 2100. This is the preoperative data where we treated mean sphere of -10 and mean cylinder of -2 diopters. So the results were comparable in both the groups. Sphere, cylinder, and spherical equivalent were excellent in both the groups post-operatively. What we saw was endothelial cell density changes, which was higher in the hydro group as compared to the OVD group, but they were not statistically very insignificant. Mean IOP pressure was very high in the OVD group, while it was compared to the hydro group, it was less. On the first day, OVD group had mean IOP spike of 17 millimeter of Hg, while hydro group was only maintaining 15 millimeter of Hg. So to discuss this topic, 50 eyes were compared in each group. OVD group had incidences in 8 eyes. In 1 eye, IOP was raised due to low vault, and ICL exchange was done in that patient after the IOP was controlled by 1 month. 4 eyes had high IOP on day 1 and day 15, and 3 eyes were maintained with anti-glaucoma regime. 3 eyes had post-operative inflammation reaction in the form of cells and flares on the first day, and it was controlled by steroids. Out of these 3 eyes, 1 eye had a task-like picture, and it had corneal edema and hypopyon on post-op day 2, which was controlled by the steroids, and it was closely followed up, and the eye was quiet and no inflammation was noted at 1 month. In hydro group, there was no such incidence of raised IOP or any long-term inflammatory reaction. Comparing the time taken for the surgery, hydro group had mean time of 3.5 plus or minus 1.2 minutes, while the OVD group had a mean time of 7.1 minutes plus or minus 1.4 minutes. At the end of mean follow-up of 6 months, endothelial cell loss was 4.8% in the hydro group, and it was 1.7% in the OVD group compared to the pre-op ECD values. So to conclude the study, I will say that ICL implantation by continuous irrigation is safe and effective, but it has a little longer learning curve compared to the implantation done by OVD. But once we execute this practice regularly, the time taken for the surgery is significantly reduced, along with minimal chances of post-op IOP spikes and lesser inflammation compared to OVD groups. These are my references. Thank you.
So you have not mentioned which OVD you used.
Yeah, we have used HPMC 2.2%, hydroxypropyl methyl cellulose 2%.
But using hyaluronate, it helps to take out the OVD faster.
Faster, yes.
So any
No.
reason why you
That is the one which we use regularly, and it is also little cost effective. But in the ICL surgery, the cost is anyways higher. But that is what we use in the routine practice, HPMC 2%.
Your post-operative or hypotensive treatment in both the groups was the same. What is your post-operative hypotensive treatment?
IOTIM, that is timolol 0.5%, but if it is not controlled with one drug beyond 1 week or 10 days, and then we would...
No, the routine post-operative
Routine is
treatment.
IOTIM, timolol.
Was it the same in both the groups? Even in the hydro group, you were giving the timolol?
Same, sir. Same. Because there is no protective effect of the OVDs which are present in the OVD group. So in the if we use OVD, it will protect the endothelial cells. Doesn't, yeah.
But was this calculations, these cases done after the learning curve or during the learning curve of using hydro implantation?
Like during the learning curve. It was done by a single surgeon, and
So any complications you had? Any complications you had
in the hydro group there was no complication that we
difficulties
noted.
and complications?
No difficulty, sir, I will say. The hydro group is much...
Anybody can do.
Not anybody can do, but definitely you need to do some amount of, some numbers of surgery to get used to the implantation and how the ACD is maintaining with the hydro or even with the visco, because it becomes little tricky while implanting the lens.
So your research question is efficacy.
Yeah.
So how do you do, what is the definition of efficacy in your study?
It is depending upon the efficacy, basically is calculated by efficacy index.
No, what do you mean by efficacy in your study?
Efficacy is the effectiveness of the treatment, basically. So how effective is the treatment, that ICL, how effective it is in both the groups. So it was quite equally effective because the visual and refractive outcomes were comparable in both the groups, sir.
So in conclusion, would you mention which would be a better technique? What would you advise people to do? Use a viscoelastic or not use a viscoelastic?
Viscoelastic is useful in the initial learning period.
But you said the study was done during the learning period itself, even for the hydro group. So
yeah, sir.
At the end of it, would you advise a shift over from the viscoelastic?
I would advise the shift from the viscoelastic to the hydro.
That's true. That's even with the cataract surgery.
Viscoelastic injection is easier because there is nothing going around there. So what was your bottle height in your study? Because that will determine the tolerance of
the bottle height is the standard 175 centimeter from the eye level.
So you are actually, it's a bold move and a good study, but you could have included the complications and what are the difficulties in doing. And also it's high myops. No? If the bottle height is high, there is something called iris retropulsion.
Yes.
So it becomes very deep.
Yeah.
So if those things, if you could have included, it would have been a very nice study. But
Yes.
anyway, congratulations. Thank you.
Thank you, sir.
Dr. Dhatri Karnam.
Good evening, everyone. Good evening, everyone. Today's my talk is about incidence and clinical outcomes following diffuse lamellar keratitis post-SMILE. So DLK is characterized by inflammatory infiltrates in the corneal interface, and it usually presents within 24 hours after the refractive surgery. Patient typically presents with pain, foreign body sensation, photophobia, and blurring of vision. Even though it is most commonly seen after LASIK, it is also seen to develop post-SMILE. In different studies conducted by Fernando H. et al., for example, higher energy level was associated with increased risk of DLK post-LASIK. In another study, there was association of thinner lenticules and larger diameter lenticules with higher incidence of DLK, although the overall incidence of DLK was much low compared to LASIK in SMILE group. So DLK is a typical complication of LASIK, and previously the studies have discussed this complication post-LASIK. It is also a possibility with any lamellar surgery like SMILE being no exception to it. Although the exact pathophysiology is uncertain, there are some risk factors for DLK, which is like excessive surgical manipulation, higher energy level, repeated use of negative pressure suction, and other agents like meibomian gland secretions, air, dust, and bacteria. Lastly, also individual patient differences in sensitivity to lasers. So coming to grades of DLK, grade 1 is with peripheral infiltrates, not in the center, and grade 2 is when the infiltrates are migrating from periphery to center, and grade 3 is also known as threshold DLK, in which the permanent scarring will start to appear. Grade 4 is with stromal melting and scarring, and there is hyperopic shift. The aim of the study was to report the incidence management strategies, clinical outcomes following resolution in cases of DLK post-SMILE. This is a retrospective study from December 2021 to 2022, and the sample size was 1,313 eyes of 656 subjects. And we measured UDVA, CDVA, and OSI, intraoperative parameters and postoperative treatment, and the clinical outcomes. The mean age was 26.5 years, with the incidence 1.37%, 18 eyes of 15 patients had showed DLK. Minimum lenticule thickness was 82 microns. The mean time of presentation of DLK was 2.72 days, with a mean resolution time of 8.94 days. The parameters UDVA, CDVA, and OSI, when compared between the presentation of DLK and resolution of DLK, they all showed statistical significant values. And when compared the CDVA of resolution of DLK with the preoperative value, there was no statistical significant difference, showing that all the cases of DLK at the resolution, they were comparable to the preoperative CDVA values with no loss of visual acuity. The incidence was 1.37%, of which 11 were grade 1 DLK and 7 of them were grade 2 DLK. And all the grade 1 DLK cases were treated with topical steroid therapy with no sequelae and no adverse effects. And the remaining cases of grade 2 DLK were managed effectively by interface wash. This is the ASOCT of the grade 2 DLK, in which you can see the interfaces, there are infiltrates in the interface even involving the center. And this is the ASOCT of the same patient after the interface wash. So when we studied the correlation between OSI at presentation of DLK with age, energy, and lenticule thickness, there was no statistically significant values. So in conclusion, a large data set, although which is not desirable, it could give us a more precise estimate of the results, and the treatment would depend definitely on the stage that it presents. The earlier it is diagnosed and managed, patients showed better prognosis, and OSI can be a helpful parameter in the management of DLK. Hence, DLK post-SMILE, when recognized and managed early using an appropriate approach, results in satisfactory outcomes without any permanent effect on the visual acuity. Thank you.
So what was the post-op management given to most of your SMILE patients, and how did you change it for the patients who you felt presented with DLK?
We give Predfort, ma'am, 4 times a day for 1 week tapering, and tobramycin antibiotic drops for 1 week, and lubricant gel and drops. So the mean age of time of presentation was between 2 to 15 days. So whenever they presented, we stepped up the steroids to at least 5 times tapering dose, and we kept calling them for a frequent follow-up. And we kept measuring the ASOCT and the OSI for the follow-up visits.
That's not much of a step up from 4 times to 5 times.
Basically, if they are, we also checked the OSI, ma'am. If it is too high, we stepped it up to 6 times. So we kept that as a sort of parameter, and we kept calling them every 2-3 days for the regular follow-up. Depending on the OSI and the type of the, how much it is involving the center, depending on that, we have stepped up the steroids.
What was the main reason that you could find for DLK in your patients? What was the
Most of them had meibomian gland dysfunction, dryness. That was the main factor which we have seen. Thank you.
The last paper in this session is Dr. Ritika Mukherjee. That is the semi-final
So I had presented this paper last year. It's a keynote address. It received the Siva Hardya Award last year. So I'll be talking about the algorithmic approach to plan a laser-based cross-linking in progressive keratoconus. We know the advantages of a laser-based cross-linking. There is an improved asphericity, so there is an improved contact lens fitting, and also a better spectacle acceptance. So the standard of the laser-based cross-linking is actually for the corneal thicknesses of more than 450 in eyes with keratoconus. And what we do in this is we flatten some of the corneal apex as well as an adjacent arcuate area. So we create a central bump, thereby mimicking a myopic cornea, which is usually the normal. So the problem comes when there is a maximum ablation of more than 40 microns, or if the initial corneal thickness is below 400 microns. So in these cases, we have established something called the TREC. So what we do in this is we ablate the zone of the cone, and this results in a minimum ablation, while at the same time giving us the benefit of a laser-based cross-linking, that is by regularizing the cornea. And so we are able to do this for corneas which are less than 400 microns. So the question that we asked was, can we compute an algorithm for safe and effective laser-based cross-linking in keratoconus, and if these had good long-term outcomes. So we recruited 300 eyes with the inclusion and exclusion criteria and the ethics committee approval. The patients who presented with a documented progression on Pentacam were also evaluated on the Schwind and Osiris-T, and we classified them into 2 groups based on the corneal thickness. They underwent a topo-guided PRK or a TREC depending on what the thickness was and what the ablation was after planning. I will be discussing that for subsequently. This was followed by an accelerated corneal cross-linking, and their visual function, tomography, and biomechanics were seen at 1 month, 3 months, 6 months, 1 year, and at 5 years post-operatively. So how did we decide whether they will undergo a routine laser-based cross-linking or TREC? We took good scans from the Phoenix software, and we exported them to the Schwind software, where we used the ORC-CAM mode. So in this mode, we first applied the 0 rule, and then we saw the ablation depth while treating only the higher aberration. That is, we did not treat any refraction. After this, we click the manager tab, which gives us the higher order aberrations. And when we click on the depth minimize, it again lessens the amount of ablation by correcting only the significant higher order aberration. So as you can see here, it has only corrected the vertical and horizontal coma and switched off. What that means is it is not treating the higher, the spherical aberration or the trefoil and other 4th and 5th order aberrations. So here we can see that, So here we can see that the central and maximal tissue ablation in the brackets came down from 28 to 19 and 8 micron central ablation. But if this is not the case, if we have a higher ablation after doing all this, this might cause an excessive tissue ablation and scarring. So in these patients, we performed a TREC by localizing the steepest area of the cone by measuring it on the Cirrus and then planning a PTK on the Schwind software. So this is just an algorithm to show how we proceeded. Basically, if there was a thinner cornea or if there was a higher ablation planned on the TGPRK, we planned a TREC. And what were our results? So in terms of the efficacy, we saw the UDVA and CDVA, and they were comparable for both the TREC and the TPRK groups. And the safety was seen by the gain of lines, and we saw almost 40% had a gain of lines in TREC and 42% in TPRK, which was significant. And they both had a spherical equivalent accuracy which was comparable, and both showed a reduction in the corneal astigmatism post-surgery. They also showed a reduction in the refractive astigmatism post-surgery, which could be attributed to a reduction in the corneal aberration, so there was a better spectacle acceptance, and that reduced the refractive astigmatism. We also saw a flattening of keratometry in both the groups, which was comparable. So we did come across a few complications. Approximately 2% patients progressed 5 years post-TREC, and 1.5%, that is 3 out of 200 patients post-TPRK. These were treated with the Dresden protocol subsequently. We didn't see any excessive flattening in patients who underwent TREC. There was 1.17% flattening in the TPRK group, and we did see a loss of lines in 3 out of 100 patients in TREC and 2% in the TPRK group at 5 years post-op. So to conclude, a topo-guided PRK cross-linking can correct the irregularities and give refractive improvement to patients with keratoconus. And a TREC has shown a similar magnitude of flattening while conserving greater amounts of tissue. So it can be considered for patients who have a thinner cornea, decentered cones, or advanced grades. And it is comparable to TPRK in terms of safety and efficacy, even on long-term, that is 5-year outcomes. And the application of this algorithm showed promising results. Thank you. Thank you so much.
So we have one more paper in the semi-final session, and I call Dr. Kumar doctor.
(394). Good afternoon, everybody. This is just a toric marker. Now everyone's talking lenticule, 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 and suddenly it's become the need of the hour. So this is what it's a very machine-based. So this I actually needed for my technology, which I'm using. It depends on what you want to use for your system. And I'll tell you why I thought of it and how it's helping my results. So this is a marker that actually marks 0, 90, and 180. Okay, that's very, very crucial. And marks both, you need to mark both in spherical errors as well as cylinder. Of course, this study was done for the cylindrical powers also. It's very relevant for both. And these marks are not visible, so the center part of the marker is clear so that the patient looks at the light, and that gives you a visual axis. And it also eliminates refractive error, so you can treat high pure cylinders. We have gone till -4 for a lenticule without any problem, and results are excellent. Now here, of course, we also did a study to make sure that we introduce a easier method of marking and how to do that. So here the method that we did is we took 50 patients with a -0.75 in this study till a maximum -5. And we took image-guided technology as a guideline and then used this marker to mark the 0, 180 and the 90. That's 0.1. So once you've done the marking, why is this marking relevant in this? I'll tell you when I'll show the next slide. And after the marking is done, we go ahead and perform the surgery. So this is done in 1 OT, and then we take the patient under the femto. So you can see that we taken the marker, make sure the back side of the marker is different from the normal markers that you see. The length of the marker is long, so you almost comes towards the center. And there are 3 parts, and once the image guided is done, you can see the third image here that you can see that it is marked there. Once the marking is done, we put 1 drop of methylene blue or a dye, so it will highlight the mark. That is one big advantage. And then do the lenticule procedure. Now the lenticule procedure that I'm using the system is the Z8, where the pressure of the eye goes up. Whenever the pressure of the eye goes up, the pupil slightly decenters. We tend to move the lenticule in the direction of the pupil. You have a decentered lenticule. The big advantage in marking here is that the Z8 system automatically aligns the mark till 30 degrees. So if you're off by 30 degrees, it's not going to align. Less than 30 degrees is automatically going to align. So even if your pupil is slightly eccentric, don't worry. Follow the mark on the cornea, and that will make sure that your lenticule is always perfectly centered. It will never ever have a slightly decentered lenticule, and that's one big advantage. So the augmentation of the mark and making sure that the pressure of the lenticule is applied once the lenticule is extracted, We got the results so small in procedure of Z8, they call it clear corneal lenticle extraction for advanced refractive correction. And this toric marking was done, we used the modified marker. And once that was done, we went ahead and did the lenticle extraction. And once the lenticle extraction was done, it aligned. So we got excellent results in 50 patients. Maximum by day 7, all of them were 6 by 6. You can see the lenticle extraction. You can see the central part very well, always well centered. And post-operative pachymetry and wavefront readings was done. Maximum we got was 0.25. So in conclusion, this marker is a necessity in not only cylinder, but even in spherical. So it works beautifully, but only thing you need some image-guided technology to help you more to align the mark always. Thank you all for your attention.
You used this only with the Z8 or you used it with the...
So if you see, I saw live surgery in lenticule on Elita. When you see the live surgery, it appears extremely decentered. But you know, this is everything to do with the camera in the system. So if I'm using the Z8, when you're doing a LASIK flap, the pupil slightly dilates, but you will move your trajectory to the center of the pupil. But we don't need to worry because the ablation is coming from the excimer laser. So you may have a slightly decentered LASIK flap, but you'll always have a fantastically centered treatment. Now this cannot be applied in lenticule. And that's the reason why if you move the lenticule trajectory to center on the pupil, you'll have a decentered lenticule extraction. The beauty here was that this mark, what we found in the other markers which are there in the market, are a little short. Now the camera angulation in the lenticule on the Z8 is different than the flap. So your amount of area that you're seeing on the Z8 is lesser or smaller. Actually it's applanating 10 millimeter, but the amount that you're seeing or visualizing on the screen is smaller. And that's the reason why I thought that this mark has to be visible to us. So I removed the center, tell the patient to look, you got your visual axis, make long marks, and then the machine automatically aligns the mark. And that, I think I had a learning curve. I was the second idiot to get the Z8 in India, and I was learning with the company, and that gave my ups and downs in my results. But what summary here is that because of this centration, all those issues have completely disappeared. So it's not, I've done the study on cylinder, but I think it's equally relevant in spherical and spherocylinder application.
Good, very good application.
Thank you. Thank you.
So I think this brings us to the end of this session. Thanks everyone for having attended. Thanks and congrats to all the presenters. You all are winners.